Thank you. So yeah, so thanks for the invitation. Sorry, I've just managed to come to this hall because I was chairing a session in the ESG symposium in the next Alpha Hall. But yeah, pleasure to be here talking about the update on closed loop systems. These are my disclosures. And of course, closed loop system and technology, I'm very much linked in with type 1 diabetes. And I put these data up to start because this shows the gap in life expectancy between people with type 1 diabetes and if you don't have it. So you see the blue dots there. If you're diagnosed under the age of 10, you lose 15 years of life expectancy, even in the West. And if you're diagnosed over 20, you lose about 10 years. And that explores the first myth that we used to call it juvenile diabetes or childhood diabetes. But the fact is that 50% of people with type 1 diabetes are diagnosed after the age of 18 in adulthood. So the first myth to explore there is that there's lots of misdiagnosis with type 2 diabetes being diagnosed in teenagers and type 1 diabetes being diagnosed in people over 25 and 30. But there's still that gap in life expectancy. On the right here, it gives a accumulation of what the causes are for that lower life expectancy. And in these younger people, aged 20 to 30, still a big part of that is from acute emergencies, DKA, misdiagnosis, and diabetic coma. But then as we get older, you can see the proportion in red increases, which again highlights the fact that 50% of this excess mortality is because of younger onset of cardiovascular disease. And often in type 1 diabetes, we're very focused on the glucose, but there's also an element of statins and other cardiovascular risk protection that we need to be in touch of. Now, diabetes, I think for the last 20 years, we've all been promoting, we need to have better access to technology. And what you see on the left there is data from the American Type 1 Diabetes Exchange. And the orange line is the average A1C in different year groups about when a survey was done in about 2013, 2014. And the blue line is the same survey done in 2018. And what you see there is the A1C is actually higher, despite there being almost a doubling in access to CGM. So just giving people a pump alone or sensor alone, it has some benefit, but it doesn't get people to target. And I think what I want to highlight here is that our target is 6.5%. And actually, you can see here, on average, we're a long way off. On the right, you can see databases. DPV is a German database with 40,000 people with type 1. T1D Exchange, 25,000. Swedish registry, again, another 20,000. And average A1Cs, even in these Western countries with established education, free access to insulin, free access to pumps and sensors, we don't achieve those target glucose levels. UK National Diabetes Audit, we have a much lower rate in the UK of pump and sensor use, and you can see our A1Cs are much higher. And why is the reason then? It's all very well telling the patient your target is 6.5% HbA1c. But to achieve that, if you go back to the data and see what do people have to do to achieve that, they have to measure their glucose 8 to 10 times a day. If you look at flash monitoring, they're measuring at least 20 times a day, the people who achieve that target. And then 6 to 8 doses of rapid acting insulin. Usually to do that often, you need to have insulin pump. Then you need to have adjustments for travel, attention to snacks, planning for exercise, accurate carb counting. And on top of that, you need some luck, some skill, some motivation, some support from your peer network, education every day for the rest of your life. And in the Indian scenario, where you have to pay for insulin, you have to pay for strips, the expertise in teaching carb counting and dose adjustment may be variable on access to it, and the societal influence of type 1 diabetes and the societal support is even peer support is even tougher to get. Then it tells you why there's a much higher rate of problems in different scenarios. So of course, we've always known that technology helps. And I've seen many patients who have started their diabetes career measuring urine glucose and delivering insulin using washed syringe, which they boil and clear from the 1950s and 1960s. And then, of course, the vast majority of people who we see now in the UK, they're doing finger prick monitoring. Average in the UK is probably about 4 times a day. They keep detailed diaries and they use insulin pens. And then we have some people who move forward now. About 5% of people in the UK use some form of CGM. We have people using insulin pumps, and we have much better data capture. And as you move from left to right, I think we are seeing progressive drops in A1C, but nowhere near target until we combine those 3 elements, the glucose sensing, the data, and the pump in a closed loop system. And so in a closed loop system, what we do is we transfer the workload from the patient and the healthcare professional onto the system. And I think one of the big advantages is that when we have people on open loop, we have people on MDI or sensor augmented pump even, the input needed by the person with diabetes and with the healthcare professional is really high. We would see this because they're having so much data, actually sometimes it increases the workload for them. And that's when we move people onto closed loop, we find it makes a huge, huge difference to them in terms of the reduction in the amount of work they're doing for the diabetes. And that in turn, we see a big change in the relationship they have with their diabetes. Before that, they were resenting their diabetes. Because of diabetes, I can't exercise, I can't do this, I can't go out with my friends. And suddenly put them on closed loop, and that quality of life benefit is really transformative. And that's really what makes it fun, moving people onto closed loop. So this is just a slide now, it's probably a year and a half old. It's a JDRF slide looking at 39 different projects looking at closed loop therapy. And from one side, you're looking dual hormones. How do we get a soluble glucagon so we can make a dual hormone insulin? And that's Xeris on the left-hand side. You've got the big industries of Insulet, Cellnovo, Tandem, Roche, Medtronic working in phase 3 or phase 4 trials. So all the big players are looking into this. You've got companies like Lilly who've purchased closed loop companies, and lots of independents, and including lots of patient-led organizations as well. Currently in the UK, we probably have the widest choice. We've got 3 currently available systems. You've got the Medtronic 670 and 780 systems. We have the Cambridge APS system, and we have the Tandem Control IQ. In the US and the rest of Europe, it's only the Medtronic and Control IQ systems that are currently available and licensed. So I'll take the Medtronic system first. And this was the first generation Medtronic system. And what I want to highlight here is the black boxes are the run-in numbers, okay? So if you look at the second box here, which is time in range for adults, you can see at baseline, these people in the study were at 66.7%. That's already an A1C of 7.5, right? They're almost at target, and it increases a little bit to 72. But the important thing here is that the blue box, which is real world data, is exactly the same as what you see in the trial, whether that's adults time in range, adults time above range, or if you look at hypoglycemia. Actually, if you look at hypoglycemia, that's first 2 columns, you see in the real world, patients have even less hypoglycemia than you saw in the studies. It's down from about 1% time. So 1% of time is about 144 minutes, in a day, is about 15 minutes a day, down to 0.6 or 0.5%. That's halving that. Hardly 5 minutes a day hypoglycemia on average people are getting. And so that's the main benefit that the people living with diabetes see. But we also look at the, of course, improved A1C. And as you roll this Medtronic 670 out across all the European countries, you can see here big numbers, thousands of patients, up to 4,000 in Italy, thousands of patients across all the different countries, ranging from Austria to even South Africa. And you can see the main thing here is this system, closed loop, is agnostic to who uses it and where it's used. It does not need patient expertise or healthcare professional expertise. Whereas the outcomes, if you look at the same figure for insulin pump therapy or education or sensors, you'll find huge variation between countries, dependent on the education, socioeconomic factors, and demographic factors. What you find with closed loop is that it doesn't matter who you put it on. There's a very tight response, and you can get 70% time in range, basically whoever you put it on. So how does this work? So basically, instead of having a flat background insulin, a bit like maybe you might use Lantus in MDI, or in a pump, you've got a basal rate. You can see here this purple graph is showing this Manhattan profile, that when the glucose is dropping down, the pump is turning off the insulin, just like a normal human pancreas would do. As the glucose rises, then in response to that, it will increase. So it's doing pulsatile insulin therapy, just like the human beta cell. Now, the first generation systems, which is the Medtronic 670 and the Tandem IQ system, do this by adjusting the basal insulin, which is actually quite clunky and quite slow to work. The second generation, which is the Medtronic 780, you can see these vertical lines here. So instead of increasing the basal insulin, which is a bit slower to act, it gives sharp boluses, sharp amounts of insulin, 1, 2 units, repeated small pulses. And it's far more effective at stopping those rises of glucose and preventing hypoglycemia. And certainly we see a big difference in our clinical practice between 670 and 780. And you can see here, this is just a picture from a patient of ours. You can see how the glucose is within range almost the whole time. In the morning, you can see this person it's drifting down, the insulin turns off, the patient has a meal, very limited post-meal excursion, hardly hits 200 before it comes down. And you can see here, in the evening, patients had a high-fat meal. They bolus, they've actually, for 50 grams, you can see there is no purple line there. So they have not taken a bolus for the meal. So they missed the bolus. But the pump then can do lots of micro boluses and capture that and still keep the glucose down to a reasonable level. Not perfect, but still manages it way better than any other system can do. And using these latest second generation closed loop systems, you can see here, 84% of participants achieve an A1C of under 6.5%. 84%. In a utopian world, if every person was using a closed loop for the first 10 years of their type 1 diabetes, there would be zero amputation, zero blindness, and zero renal failure, actually, because people will be at target. This is just some data that we've done from our clinic. And again, there's a lot of talk about open source closed loop systems, and I'll talk to them a little bit later, but we did a comparison in our clinic of users using the Medtronic system and the closed loop, the DIY system. And you can see that DIY system is almost 10% greater time in range with no real difference in hypoglycemia, with a big reduction in these very high readings. And that's because the open source systems are far more aggressive. You can set lower targets, and it uses those boluses, things that are now incorporated into some of the second generation closed loops. The second option on the market that's widely used, and actually is a lot of patients really like this, which is the Tandem system. And the big difference with Tandem is it uses the Dexcom sensor. And for a lot of people, that's a game changer because the Dexcom sensor doesn't need finger prick calibration, but the Medtronic system does. And often for patients choosing which device to use, that is the biggest thing. Even if the Medtronic system is slightly better, they will say, I want to go for the Dexcom because I don't want to do finger pricks. Also, the pump is slightly smaller. It's touchscreen, so the form factor is much nicer. And again, the way it works is very similar. It works on basal adjustments. And these are some data just published very recently, shown at the ATT meeting last week. And these are real world use from 10,000 users of closed loop therapy. So we're used to randomized controlled trials of 100 patients here, 200 patients here. Even for big drugs like empagliflozin and GLP-1s, we might have a trial of 4,000 or 5,000 people. But with real world evidence, we can look at 10,000 users. And again, what you see is this pretty tight band of interquartile ranges. Whoever you put on it basically gets to about high 70s time in range, and it happens straight away and is sustained. There is no drop off over the year. Time in hypoglycemia, you can see here, time below 70. In this cohort was quite low at the beginning, only 1%, so it stays there, but the variability, these people with very high time in hypoglycemia is reduced down with this system. So again, it kind of, whoever you put on these systems, they do the same, and that's the magic of these systems. And once they go onto it, their need for continued support, continued help from the healthcare professional goes away, because actually the glucose is in target as soon as you start the system. If you look at these are just a little bit more detailed data. So what these are cumulative graphs going from midnight to midnight of the whole year of data. And you can see overnight, when the person is not eating, you can see the increase in time in range. They almost, as the system grabs control of your glucose once you've gone to bed, the system can get you to 90% time in range overnight. As the person eats, the time in range drops, because the post-meal glucose, again, the post-meal glucose excursions are dependent on the carb counting ability of the individual. But you can see here, it never drops as low as it does in open loop. What's interesting in this from this publication was that there were 10,000 people using closed loops, but about 20% of those people, so probably about almost up to 1,500 to 2,000 people, were type 2 diabetes. And you can see exactly the same response in type 2 diabetes. Now, I think this is really interesting, particularly for the Indian market, where you have lots of people on high insulin doses, young people with type 2 diabetes, where maybe I can, if I make an assumption, probably a bit like America, the people with type 2 diabetes who are at the higher economic level, who can afford some therapies, This is a much easier way for them to get control. And the fact that it works in type 2 diabetes, this is one of the first examples of large number of patients showing benefit in type 2 diabetes. The third option is the Cambridge diabetes system. This uses a Dana pump. This is a Korean pump that is really nice and lightweight. And it is a Dexcom sensor. But the advantage of this system, which is why some of my patients, particularly the people who are working in busy jobs, choose this, is it's completely controlled on the phone. So a lot of patients who may be working in a client-facing environment, if they're sitting with a client and the client offers them a coffee or some snacks, they don't want to take the pump out and press some buttons to give the bolus at the moment. They find it much more easy and discreet because this closed loop system runs off an app, and they can just open the app and click a button and take that, say I'm having 10 grams of carb for my coffee, I'm having 30 grams of carb for this samosa, and deliver that. And the discreteness of the system is really, really what sells it to people. It's also a bit more adaptive with what targets you can set, and it's the only system that is eligible for children under 7 years, and it's the only system that's eligible and proven in pregnancy. But again, you can see this Manhattan of basal rates. The pump is continuously changing the background insulin delivery, just like the human pancreas does, in response to glucose. And then when the meal comes, you can see these spikes here, 2.9, 2.1. These are spikes that still the person has to tell the system that they're eating. And coming soon at the ATTD, we saw some really nice data from the Omnipod Horizon system. For a lot of patients, the fact that this is a tubular system, again, managed off a handset, is hugely beneficial and attractive. And I've got a lot of patients who are waiting for Omnipod to come out with their system before they go on closed loop. Kaleido has a system as well, which is tied in with a French group called Diab. And again, these are two systems that will probably come. I think the trials and the FDA approvals were delayed by COVID. So instead of a launch at the end of 2021, we're looking to sometime in 2022 for these systems to come online. Again, the Omnipod system has the flexibility of using different target levels. And you can see the time in range you achieve is really dependent on the target level you get. And that's why the early Medtronic systems, you could only use a 140 target, used to get a lower time in range. With the newer systems, you can use a tighter target of 110 milligram per deciliter and achieve that 70% time in range that you're looking for. And finally, briefly, I'll talk a bit about these DIY closed loop systems. With the lack of availability of commercial systems in India, there are a number of patients and patient organizations who are connecting with international groups and using these loop or DIY APS systems. And basically, these are, you use a commercially obtained pump, and you can use a cheaper pump like this Medtronic VO system or Paradigm system or a Kaleido system. You use a Riley link, which then is able to communicate with that and the app. And you download on the app a software that is written, it's not approved, it's written by software engineers who live with diabetes, and they use knowledge of these predictive algorithms that they use. Maybe, it's the same algorithm that traders use trading stocks. It's the same algorithm that people, one of the guys who works in closed loop therapy used to work for British Petroleum, and they manage the pressure within a refinery. The mathematics behind these closed loops is very similar and common, and people can use that, download onto apps and use that. Three main systems, Loop, OpenAPS, and Android APS, pretty much do the same thing. So how does it impact our clinical practice? I think certainly at the moment when we are advised, someone says, I want to use a pump, I think we should say, are you going to use it with a closed loop or not? Because that defines which pump you use. That's the biggest outlay. The choice of algorithm, there's not a huge amount of difference. They all achieve very good control, but we have to have patient expectations. Once you start it, we can't adjust the algorithm. If it's not delivering, we can't adjust the technical delivery. We have to adjust the patient behavior there. And the education we give people changes completely. It changes to how do we keep people in auto mode and how do we keep them safe if the sensor fails or if there's a pump problem and they come back into manual driving, as it were. So I think we're really at the cusp of this situation where we used to have sensors and pumps and injections and MDI and SMBG. And we used to say, if you want to get good diabetes control, you have to work harder. But I think now we can use the technology to work smarter. And if we have the ability to fund these systems, or people have the ability to fund the systems, then they are really, really worth it in the long terms. Thank you.